thank you, LJ. Thank you very much for the chance to present. I'm actually genuinely very excited about this topic and glad to be able to present the data on this. So the topic in general is one of those that has been around for decades, and yet there's not been a ton of good data out there. So hopefully we can address that a little bit. So I don't have any disclosures that are relevant for this talk. So by way of background, as we know, reversals are a good option for restoring fertility post-vasectomy. And the goal really is to achieve about 5 million. So both Silber's study, old data, 1992 study, Majoub's study, our internal data consistently show that if you're above 5 million, you pretty much optimize at that level. So whether you're 5, 15, 55, doesn't really matter. That's where you're going to see your pregnancies that have bumped. When you're below 5 million, you get a drop-off that occurs there. Now, there's a lot of failures that can happen with a reversal. So either you can do the wrong surgery just outright. They needed an EV, but you did a VV. You could do it incorrectly. You just back wall a suture or something where you just close it off from a technique standpoint. It could pull apart, in the post-op that just didn't have enough, reinforcing type sutures, or they're too aggressive with it. The bottom two, though, are where prednisone really kind of comes into play here. So that it can either stenose at the outset or it can stenose long-term. So it's patent for a little while and then it stenoses long-term. So really, this is where prednisone theoretically or hypothetically can have some potential role, and that's what I'm going to kind of focus on today. Now, prednisone is not a new concept, as we know. So this was 1953. I dug this one up, or 1957. I actually had to get this from the stacks at Mayo because you can't get this online very easily anymore. And this was one of the first reports of cortisone looking at vasovasostomy specifically. And no question, glucocorticoids do have an impact. They reduce collagen, they thin skin. There's no question it reduces scar tissue. The question is, does it prevent this type of long-term stenosis or delayed stenosis? So again, it's been debatable for as long as I've known of it. So 1980, there was a study, 40 men. They did 40 milligrams for 6 weeks, so a much higher dose than would be kind of in contemporary practice. And here, again, the 1980 study, the quality is maybe a little bit different than today. Sperms in semen is 95 versus 70%, pregnancy 55 versus 45. But they used a suture stent with this. There was no operating microscope. And when you look into the study itself, the data are very suspect. So, what do you do with this? But it's out there. There's several other studies looking at prednisone to reduce anosperm antibodies, but again, huge limitations with these studies. They have tiny samples, varying populations, no microscope. Both male and female factors are present. And honestly, who cares about anosperm antibodies in 2024? That's kind of an old topic. That's early 2000s type topic, not anything that's real contemporary today. Well, renewed interest in about 2020. So this study was probably the main one. So the Machen study, the 89 men who underwent a prednisone taper for 20 milligrams for 2 weeks, then 10 milligrams for 2 weeks, if the patient had 0 sperm or declining sperm. And they showed that your concentration boosted, and those who had 0 sperm were more likely to respond in that area. And then there's a second real small study, eight men. If they had a greater than 50% decline, they improved 100% of the time. So these were the preliminary data. Actually, that second one was just brand new. It was well after our study got underway. But in particular, that 2021 is what kind of renewed the interest in our side. So the problem with both of those studies, though, and problem in a lot of fertility studies, is this floor effect bias. So if you go from point 1, so if you go all the way up from here down to here, and you treat this guy with anything, you give him dirt, you give him teeth whitening, you give him like a real nice, let him read something fun, his sperm count's going to go up just because it can't go anywhere else. It's a floor effect. And so real commonly, you'll get on forums, groups, things like that, and they'll say, oh yeah, I took whatever and I got pregnant. And good for you, but that's just what happens. Sperm counts go down, they go back up, and that's just natural variability in these. And that's the problem with these types of retrospective studies. Oh, they had terrible outcomes, I gave them something, and look what I did, I cured them. Well, maybe, but you don't know until you do a randomized prospective type study. So we said, hey, we do a bunch of reversals, so if anyone should do this, we should probably do a randomized trial on this. So we broke them into 4 groups. There were 25 men in each arm originally. The first group was control, so it was just reversal, nothing else, no NSAIDs, no corticosteroids, anything like that. Second group was this taper, so 20 milligrams for 5 days, 10 milligrams for 5 days, and then 5 milligrams till they, for another 20 days. And they got it month on, month off for 3 months. So month on, month off, month on, month off. And then the prednisone PRN group, if you had a declining sperm count or were 0, then you got that same course, 20 milligrams, 10 milligrams, and so on. Now that fourth group, originally were supposed to have microscopes. We'd send them home with a microscope. If they didn't see sperm or didn't see motility, they would take a course of the prednisone, and if they did see sperm, they wouldn't. The problem was they kept breaking the microscopes, they couldn't figure it out, and so finally I just said, and just out of the blue, just came up with numbers and said, okay, let's do 5 milligrams daily, thinking it would be like a sham treatment, because your body naturally makes about 3 or 4 milligrams, and so thought, okay, that's going to be my sham arm, just to look for placebo effects here. We did restrict it to a single surgeon, so we didn't want the bias of having multiple surgeons potentially impacting it. And we excluded anyone who had female partner factors, so it was only 35 and younger, no known factors there. Primary outcome was pregnancy, secondary was sperm kinetics. So the only thing I want to highlight out here, you're not going to be able to read much of it, but basically it's a randomized trial, so the data are matched. Like, in fact, if you submit something to New England Journal and you try to give them a demographic table, they throw it out just because it's a randomized trial. That's the whole reason you do a randomized trial, is because they're matched. But I do want to highlight, so the high group, they did get all 3 courses of the prednisone, whereas the PRN group only ended up a median of 1 course. Now that's going to be important in the graph here in just a second. So it's a dose response difference that we're going to show in a second. So 3 courses, so 3 months total, 1 month total, and again, that's median as far as number of cycles. Now, and the last there too, every group had EVs in there too. The high group did get 2 patients who had bilateral EVs, and it's just a function of randomization. When you pre-stratify things, you're going to have things like that that'll pop up with it, but not significant between groups. Now, this was a shocking finding to us. In fact, it was real kind of exciting and shocking at the same time. So the control group and the real tiny dose group did equivalent from a pregnancy standpoint. The first blue bar is the first 6 months. The orange bar is the last the first year combined. But the high dose group did the worst. They just didn't get pregnant. And it lasted a long time. So the last dose here was 6 months, but they still weren't getting pregnant all the way out to a year. Whereas the PRN group, remember this is dose response, they had a lower dose of that high dose of corticosteroid, got pregnant at a lower rate compared to those who had a lower dose with it. So the interim analysis I did showed that this was statistically significant. It just felt too unethical to keep enrolling, so I stopped enrollment in those 2 arms. I wouldn't want to be in one of those arms, so we stopped the enrollment there. Interestingly though, their sperm counts did great. So the people in that high dose arm, if anything, were doing higher or better than the other ones. So this helps explain why, from a clinician standpoint, I give prednisone, I feel good about myself because their sperm counts look a little bit better, but they're not getting pregnant, and hence you keep them on prednisone pretty much forever because they're never getting pregnant. And this is just broken down every single month. We did a median comparison, and they're similar. There's not a single month where suddenly you see one dropping out versus another, so it's probably a real result. So the results fail to suggest any true benefits of using high dose, so 20 milligram type tapers, to increase sperm counts, improve pregnancy, improve patency, or even salvage low counts, period. Now it's only testing that particular protocol. Of course, you can make arguments for different protocols, but the data are pretty conclusive from that standpoint. Now, if you say, what about the low dose arm, the 5 milligram dosing? I pulled out all the other data except the low dose. Low dose is blue here, and control is whatever color that is, reddish. And are we starting to see a separation occurring there? I don't have the 2-year data yet. In fact, I just sent out an email saying, hey, let's get more of the 2-year data so we can answer this, by AUA type thing. But I did pull our data yesterday. So I looked at our prospective database. We have 3,600 men we've done reversals on the last 4 years. And we looked at this spread. So orange is the people in the low dose group, and blue is the people in the non-low dose group. So as a wholesale, as a practice, we switched over to using this regularly because of these results. Now it's a little biased though, because we got better over time and we started doing other corrections and other technique things that improved results. So I don't know how much of this is pure prednisone, but it's enough that makes me say there's probably something here. Now, is there a mechanism? It does make sense. You get in a car accident, it's a terrible time for pregnancy. Your body doesn't want you to get pregnant in those types of situations. It also explains this stress hypothesis, why couples can't get pregnant despite negative evaluations. And we see it, congenital adrenal hyperplasia, they have reduced sperm production. It reverses when you give them steroids. And there are glucocorticoid receptors near the testicular cells. So it's a very exciting new area of research completely in the field of infertility. So in summary, glucocorticoids post-reversal is controversial, but the best data says that there's harms with doing 20 milligram tapers. Lower dose prednisone might have a benefit there. Now, if you say, of all the data I've seen, everything we've done over all these years, I think it probably has a small effect in the low dose, and so we do it in our practice. But it is one of those you just need a little more data to know for sure. With that, I thank you for your time.